Hello friends. So today we'll be discussing a topic in pediatric surgery and general surgery, that is Hirschsprung disease. So before starting, I would like to thank Chandana Shri Ma'am for sharing these wonderful notes with us, which are very helpful for quick revision. The link for the notes is given in the description below. You can download it from there. So without further delay, let's get started. So what is Hirschsprung disease? So it's a developmental disorder with absence of ganglion cells in the mesenteric, that is Orbax, and submucosal, that is Meesner's plexus. So neurological cells are absent in the GI tract. So what is the embryological basis? So there is craniocaudal migration of ganglion cell and it begins in the 12th week. If this migration is deficient, so that will result in Hirschsprung disease. So earlier the migration stops, longer is the aganglionic part of the distal bowel. So more is the earlier the migration stop, more is the segment that is affected. Then neurogenic parasympathetic abnormality. Aganglionic bowel, it is unable to relax and propulsive waves stop at the proximal end of the aganglionic segment. So it is not able to relax and accommodate the content which is coming from behind or proximal part. So there will be muscular spasm of the distal colon and internal sphincter, functional obstruction, causing functional obstruction, and dilatation of bowel proximal to the aganglionic segment. So the proximal part will be dilated and this part of bowel is normal and the part which is not dilated is affected. The scenario incidence is 1 in 3000 to 5000 live births. Male is to female is 4 is to 1, more common in males, and familial in up to 10% cases. And mutation which is seen is rectoproto-oncogene mutation, and it is associated with Down syndrome. Then the classification, most commonly it occurs in the rectosigmoid region, long colonic, total colonic, and jejunal. These are the less common areas where it occurs. Presentation is in the neonatal period most commonly, and it presents as abdominal distension, bilious vomiting, failure to pass or delay to pass, stool or meconium, then poor feeding and constipation. Emergency can rise from this, that is enterocolitis, which is the most dreaded complication and is the most common cause of death also in this disease, where the baby presents with abdominal distension, foul smelling stools, fever, sepsis, and rapidly causing death if not treated timely. Then coming to the evaluation part, the history, distension and vomiting, not passing stool will be suggestive. And to evaluate, we'll go with contrast enema. In case of megacolon, the transition zone will be showing difference in the caliber. So if rectum is narrower than sigmoid, then it is associated in the rectum. The pathology is associated in the rectum. Anorectal manometry, so that will show missing rectoanal inhibitory reflex. Rectal biopsy will be diagnostic, so there will be no ganglion cells and thick nerve trunks. Immunohistochemistry will show acetylcholinesterase and calretinine immunostaining. The activity will be increased in lamina propria and mucosa. Then coming to the management, in case of stable patient with mild symptoms, we can continue oral feeds and daily emptying of the bowel with help of saline enemas. We can plan for surgery without much difficulty. Whereas in case of emergency, we have to go for bowel diversion for fulminant enterocolitis, because long segment or total colonic, also in long segment total colonic case, it is not fit for immediate surgery. So we have to go for emergency colostomy. Here we go for a leveling colostomy where the bowel segment above the transition zone with normal innervation and caliber is brought out. And we also confirm during the time of surgery by frozen section. and we can subsequently pull the normal part without the need for ganglion status, need to confirm the ganglion status. And this will be a type of bridge colostomy where there will be both stoma barrels and they will be separated by fascia or a skin bridge. Then we'll be seeing the definitive procedures, which are Duhamel procedure, Swenson's procedure or rectosigmoidectomy, or Suave procedure, that is mucosectomy. Then fourth is the Delator operation, that is transanal surgery, and Reben anterior resection. Now coming to Duhamel procedure, a ganglionic rectal stump is left in place and ganglionic normal part will be pulled out as a stump. So ganglionated colon part is pulled behind the stump and rectal stump is left in place, is closed. Then stapler is introduced in the anus with one limb in the aganglionic stump and other in the ganglionated colon, and firing we create a new rectum, as you can see in the diagram. Here the contents will empty normally due to posterior patch of normal bowel and will able to function. Then we come to Swenson's procedure, that is rectosigmoidectomy, where the aganglionic bowel is removed and the normal bowel, that is ganglionated bowel, is brought down to the level of internal sphincter and coloanal anastomosis is made. Then Suave procedure, that is mucosectomy, where the endorectal mucosal dissection is done within the aganglionic distal rectum. Ganglionated normal colon is pulled down through the remnant of the muscular cuff and coloanal anastomosis is done. And this can also be performed by lap or can be performed transanally. It is popular because here we can avoid colostomy. Then Delator operation, that is transanal, through circumferential incision above dentate line. We go for mucosal dissection up to the peritoneal reflection and posterior myotomy in the muscular cuff. We pull the aganglionic bowel segment out of anus and resection is done at the transition zone and normal colon is sutured to the resected side at the dentate line. So here we go transanally, remove the aganglionated part and bring down the ganglionated part and suture it, anastomose it at the level of dentate line. Then Reben's anterior resection. So here after resecting the aganglionic segment, we do anastomosis abdominally using staplers or a hand sewn technique. Then sphincteromyotomy. Here it is indicated in patients with internal sphincter achalasia after an operation. So if the patient is having an issue of internal sphincter achalasia, that is malfunctioning, then we go for this surgery. And lastly, hypoganglionosis or intestinal neuronal dysplasia. It also presents similar to Hirschsprung, and the management will be controversial in this case. So this was all about Hirschsprung's disease. Hope it has been understood in simple words and can be easy for revision. So keep studying, keep growing. Thank you for watching. Please like, share and subscribe and never give up because great things take time. Thank you. See you in next video soon.